All right, so thanks again, everybody joining us tonight. This is, I don't know what number of these we're on now, but we're doing our running fall virtual panel series. And today we're talking about ultrasound with our ultrasound all-star squad here joining us today. Got the whole squad here. And so I'm gonna do intros with you guys at the just at the end of the first couple of slides here, so hang tight on that. You guys who've been here before know we do just like 2 brief slides on the program, especially for you guys who may be not as familiar with us. And then we'll pivot hard and just talk about ultrasound the rest of the time. As always, we're aiming for like 30 to 45 minutes here. So we always start with these, our program's leadership and beliefs. The first is to train expert, empathetic emergency physicians. The second is to create an environment of wellness and support. We're a really busy ED. We see a lot of very sick patients. Residency can be stressful, and so it's really important that we sort of stress that balance and wellness. The third is individual career preparation. Kind of one of the things I really valued when I was looking at residency programs is I wasn't totally sure what I wanted to do, whether that was academics, a fellowship, go to the community, whatever it may be. And so I loved that Christ was a program that was kind of devoted to preparing me for whatever it was that I was interested in. And so that's one of our kind of guiding tenets here. And the fourth is diversity and inclusion. Basically, we believe that diversity is strength. We have an incredibly diverse patient population. And it's always our goal to have a program that in some way kind of mirrors those patients because we believe that they're an incredible strength. And so each week we talk about one item that kind of supports one of these basic tenets. Today we're talking about ultrasound, which I guess probably falls into the expert physician. In Kish's case, individual career preparation, probably a little bit of all of these here. But so just as a little bit of background, give me one second. There we go. As a little bit of background, in terms of like ultrasound exposure that each resident will undergo or receive at the program. During your orientation month, which is probably more about getting to know your classmates and the ED than it is about learning medicine, there is dedicated ultrasound time. There's a running longitudinal didactic curriculum of ultrasound throughout the 3 years. And so we'll have dedicated conference days where it's basically entirely ultrasound focused. And that may be regional blocks, or I think we did echo not too long ago. We'll pick an item and work on that. Usually there's a kind of more classic didactic component to lecturers, Lambert throwing up cool pictures and stuff in an auditorium, and then we kind of break out into small groups. We've got 9 RDMS trained faculty now on staff, and a lot more who are very, very good at it, even though they may not be RDMS. Mike Lambert's here joining us, the fellowship director. And our ultrasound fellowship was founded in 1996, which what is it? We're the longest continuously running ultrasound fellowship in the country, I think. Is that right, Lambo?
That's true. For 7 years, we're the only one.
7 years we're the only one. That's interesting. Maybe a little historical perspective here too. So we're an old emergency program, and we're an old ultrasound program. And as you spread out on your interviews, you probably meet a lot of people who trained or know Mike very well. Let me let it just a couple more, one sec. Okay.
We actually started our program in '94.
Oh, is that right?
Not the fellowship. I mean, we started training residents in '94.
Okay.
But
in ultrasound, you mean?
Yeah.
Cool.
Our first machine, we had a Biosound A2000, and it had a mechanical probe on it that rotated. So we've been there for a long time.
How big was it?
Actually, it wasn't that big of a machine. It was, but the probe, is like a little circle, and it vibrated in the middle. So
that's crazy. Yeah, that's crazy. I'm sure the image quality has improved just slightly.
Oh yeah, for sure.
You got a picture here of Mike. This was, it's probably time to update this picture. That's Brett as a resident. Yeah, so that's a while ago, actually. At one of our ultrasound labs, probably, it looks like maybe practicing a fast exam or something, but some of that hands-on teaching, I think all of us would take the the best way to learn, and I think what Lambo and Katie, you guys are really great at, is when I would try and, like, as a resident, when I was training, to have one of you guys guiding that probe to get you the perfect image was kind of, it was like Cliff Notes for ultrasound. Was the best. I got pictures of you guys traveling the world. Katie, that's Katie with Andre, who's one of our former APDs and is now actually the chair at Mayo in Arizona, I believe.
Yeah, I got to dinner with him 2 nights ago.
There you go. I love Andre. So that's Katie and Andre and Dubrovnik. Katie, were you teaching a course? Or what were you doing there?
Yeah, this is the best one to be involved in. This is a Mediterranean emergency medicine course. So obviously it's going to be great locations. So yeah, it was Dubrovnik, and Mike and I were the directors of the pre-conference courses. So at any of these national conferences, a lot of people show up a couple days ahead of time and they have pre-conference courses. So there's a beginner course and then an advanced course. And so we ran and directed that course. We primarily work with AAEM as well as the European Society of Emergency Medicine. So I think the picture on the right is from AAEM in Las Vegas. But yeah, allows us.
Monica was the research fellow, or excuse me, the ultrasound fellow the year before Kishi. Looks like you guys are presenting research there, yeah?
Yep, that was in AAEM in Las Vegas, I think 2019. So
nice.
Yeah.
They only travel cool places. That's like an ultrasound thing. You guys never go to cool
Yeah, I know. Scotland, Vienna, I think. Where else?
Yeah. I picked
South Africa? You're wearing your South Africa
shirt.
I picked the wrong niche. I should have gone to ultrasound.
I know. So this is what we do. You mentioned the wellness aspect of it. When we're traveling and teaching, then we have wellness. Like we went shark diving in South Africa after we taught the course, and Mike Lambert's actually wearing his shark diving sweatshirt. On this.
No, I was outside. It was cold.
You know.
I survived the Great White Attack.
Well, my wife actually got hit by one of the sharks. She came through the tank or the cage and bumped her. Didn't bite her, but bumped her.
That sounds horrifying. Make sure your disability insurance is up to date.
Yeah.
Continuing on with the curriculum, excuse me here as we go off on tangents.
Yes, yes.
So each resident undergoes takes part in the ultrasound rotation, which is 2 dedicated weeks of just purely ultrasounding during their first year. We document this as 80 scans, and that's just because our residents are really bad at logging and documenting their scans. I can't imagine it's not double that. You'll continue with supervised scanning each week of that rotation. Our residents, again, are documenting 200 to 300 scans per residency. And again, I think that's because they're just really bad at documenting and logging these things. But the reality is you're using it every single shift at this point. In 2020, I can't think of a shift where I didn't do a couple of echoes, look at somebody's eye, something that you're using ultrasound. I got a picture here with Elise Hart, one of our faculty who just left us from Minnesota with her husband. And she is using that's the new TE probe, right, Katie?
Yeah, this is this photo is actually when they came to kind of demo the system, but we have a sim trainer called Eve, and it has the HeartWorks application, which is what you're seeing right there. So she's using the TE trainer to look at a mid-esophageal 4-chamber, which is great because we actually got a TE probe that we use in the emergency department during resuscitation. So during cardiac arrest or in someone that's just been resuscitated, to kind of get a good exam. It's been a cool collaboration with cardiothoracic surgery, cardiology, anesthesiology in training our docs and getting residents involved too.
And we'll talk, no doubt, talk more about that just shortly here. So before we kind of get into the beef of this, I was gonna have you guys just do like a formal intro of yourselves. Maybe just tell us like where you're from originally, where you went to school or trained, and kind of what your position is and what you're doing now. Lambo, we'll let you go first. You can have the
All right. Well, I am the fellowship director because Katie, I haven't talked her into it yet. So it's right around the corner. I'm a nomad. My dad was in the service, so we kind of buzzed all around the place. We lived every place for a few years at a time. So I call Chicago home, and when people ask me where I'm from, that's what I tell them, from Chicago.
And how long you been at Christ now?
33 years.
There you go. 33 more to come. Katie, we'll let you go next.
Cool. I'm originally from right outside Chicago, Oak Park, River Forest, and went to medical school down in Nashville, then came back to Chicago for residency at Advocate Christ, which was great. I loved it so much that I stayed on and did a year-long ultrasound fellowship and have stayed on as faculty as the assistant director.
And Katie was my chief.
I was.
When you are somebody's chief, that's what they always stay as. Kishi, I hope I stay as yours then. That leads us to Kishi, who can introduce himself last.
So I'm Patrick Kishi. I'm from Phoenix, Arizona. Went to college there and medical school at University of Arizona, and then wanted to expand out, never left the state. So found Chicago and found the Advocate Christ program. So I actually just graduated this past June, and I'm the current ultrasound fellow here, and it's been great so far. So
you, if you hear the residents referring, Kishi was known as Chief Kish when he was a chief resident, and that name has stuck with him. So when you will hear people refer to him as Chief Kish, that may just stick around for a while. So, as is tradition here, I'll invite you guys. If you've got questions, you can either interrupt us and shout them out. If you don't want to, you can throw them in the comment section. I have just like 2, maybe 3 of them that were sent to me ahead of time, so I can kick off with those. But like I said, feel free to interrupt or shoot them into the comments. Let's see. We'll start with Kishi. Let's start with you. In terms of these applicants on the thread right now are obviously, they're looking for a program that's going to help prepare them for the future and train to be good docs. You are now the ultrasound fellow. During your training, how did you, how did you tailor your curriculum towards ultrasound application and becoming a fellow? What sort of extra things did you do, and how did you use your elective months, things like that?
yeah, absolutely. So I wasn't quite sure what I wanted to do when I first started at Advocate Christ, whether I wanted to do fellowship, community, or what have you, but ultrasound's used pretty heavily in our shop, which is pretty nice. We have 2 Sonosite export machines that are pretty accessible and easy to use. So I feel like no matter what, like Stroni, you were saying, ultrasound is being used during every shift. And so I started using it more and more and really enjoyed it. And the nice thing about the Advocate Christ residency is we get 3 months of elective time, which is pretty rare for 3-year programs. And so that allowed me to do a full month of ultrasound elective during second year, which kind of solidified my decision to pursue a fellowship. But in addition, there's plenty of teaching opportunities. We have medical students rotating through the ultrasound rotation here. A lot of our senior residents want to get extra training there, so they have opportunities to do their elective. And research-wise, there's good research opportunities. I would say I did like a case report of a tamponade within like 24 hours, and then actually Lambo, Katie, and Stroni all here, we kind of did this poster that we just presented at the European Society of Emergency Medicine about a month ago in a study we did for lung sliding, which was pretty cool. So we all should have been in, Copenhagen, but it was, we did it virtually and it was great. But yeah, so I think there's plenty of opportunities available, and, ultrasound's used frequently and daily and every hour probably in our department, which is pretty nice. So if that's something you're interested in, there's plenty of opportunity.
Kishi, that reminds me, when this is all over, we should still write that up as a manuscript so we can start working on that now.
Thought I was done with it.
Yeah, exactly. Just because you matched the fellowship doesn't mean it ended. So it was a good study. That was a good study. It was a lot of work. Katie, maybe I'll have you walk us through a little bit. Yeah. Just give an idea of what the schedule is like for the ultrasound rotation. What is that experience? How much hands-on training? Kind of all that stuff.
Sure. So ultrasound days are primarily Tuesdays and Thursdays. When the residents come on, Tuesday usually starts with ultrasound lecture. And what's great is that you can kind of tailor it to things that you want. So we often ask our incoming interns, hey, is there something that you're interested in learning? And initially it might be like, man, I just got to get the basics, right? Like physics and echo, things like that. But as you get later in the year, someone says, yeah, I just finished my MICU rotation. Can we do a little bit more of an advanced cardiac? So that's great in that it's kind of personalized for you when you're on your rotation. That's usually followed by hands-on scanning in the department, and you go with the ultrasound faculty members as well as the fellow. And what's great is that we have so much pathology and certainly diversity with our patients in the emergency department that you're seeing really cool stuff. You're not just doing an echo because there's someone with a, with a chest there. You're doing it because there's another physician that's working in the emergency department that's saying, hey, I'm a little bit worried that there's something going on. And so you're going to see, a pericardial effusion. You're going to see right ventricular strain, pulmonary embolism, heart failure, things like that. And then Thursdays is our tape review day. And so that's where we go through all of the scans that have been recorded over the past week. And it's cool. It's kind of case-based. So we'll be able to then look up the patient and say, gosh, that heart looks terrible. Wow, they ended up, on ECMO later, things like that. And so you're learning from the scans that you've done in the past week. And then there's also independent scanning time. So that's where you as the resident can go around and scan in the department, do some extra learning sessions with the fellow, things like that.
And what that means, like on the other side of that is like, I'm usually one of the attendings in the room. And what that is typically Kish or somebody will come up and they just say, hey, we're trying to work on echoes or we're trying to work on ocular exams. Who do you have that we can look at? And so I think Katie pointed out, but the nice thing is being in a department like that, there's always patients to scan who have the pathology that you're looking for,
Yeah, and I think another thing that we've started doing, especially with this sim trainer, the sim trainer that we have not only has the transesophageal echo capability that you saw that picture of Elise Hart doing the TEE, it also has scanning ability for transthoracic and transabdominal. So what's great is that I know Patrick many times will bring the interns down to the sim lab and just have it set up for an hour and kind of go in there, and it's almost like a patient sim case where he has got a little iPad and he can kind of click like, I'm going to put fluid in the right upper quadrant, left upper quadrant, and pelvis, and we'll add an ectopic pregnancy, and you're really scanning on this very lifelike model and seeing that pathology. So it's another great way to learn.
All right, sorry about that. Katie, will you or Lambert or anybody give us a little bit of background on kind of TE, how you guys got to the point we're at now, where you expect it to be going? This is sort of like cutting edge stuff, I feel like when I was a resident, this was the stuff of podcasts, and now it's the stuff of emergency departments. And so tell us kind of give us a little historical perspective on the training you guys had to go through and how you're using it currently and where you're looking to use it.
Sure. So, I think that as it started to become, more in use, I mean, really, it's a very new technology. There's not a lot of places that are moving forward with TE or have started their process yet. But the reason it's in use is because there are a lot of patients where you can't get a good transthoracic cardiac exam, patients with COPD, poor body habitus, a multitude of reasons, and you're missing out on opportunities to provide kind of life-saving efforts and resuscitation in the setting of TEE. You're coming from inside, from behind the heart, so you don't have any of that extra fat, unfortunately, or air or lungs in the way. So it gives you a really crystal clear picture of the heart. I would say kind of how we started going, Mike and I started going up to the OR. It was Pat Pappas, right, that invited us. He's a cardiothoracic surgeon.
Yeah, I think, the other thing, Mike, is that what we found too along the way is doing CPR on patients with this TE probe in really helps verify your compressions really over the left ventricle. They found in these studies that most people are compressing over the aortic outflow tract or over the root. And it really, I think, may change the way, forever maybe, that we do CPR and resuscitation.
Mm-hmm.
So Katie,
I think
go ahead.
Go ahead. I was going to say, in kind of figuring out that, this is something we need to do and not something that you're necessarily trained on in residency yet. we went up to the operating room, and Mike and I and Elise and several others were invited into the rooms for the cardiothoracic surgery, where they drop a TE probe right away at the beginning of the surgery because this patient's getting an LVAD. And so they'll do a full exam, and they were like, "Oh, sure, come on in," and they kind of showed us how they're putting the probe in and their intubated patient. And, so we're kind of learning from our colleagues there, and then being able to use that within the ER and train more attendings, get residents involved, things like that. So.
Yeah, I think our rate limiting step is just getting more and more attendings certified to drop the probe down them, during these arrest situations. But we're on path, I think.
It seems like the only people who love Echo as much as you guys is the crit care docs in our department. It feels like you guys have been working pretty closely with them on this. Is that true?
Right. We have 2 TE probes down in the emergency department. I believe there are 2 of the critical care guys that are certified, and then at least 2 or 3 more who are planning to get certification. So, hopefully, we'll have plenty of people that, each shift you at least have somebody on that can drop these probes in these arrest patients.
I feel like Jenny Stinkcat is working a bunch of nights now. She's got to be. Is she trained yet? She's got to be.
We're getting her. We're getting her.
She was just at a class recently too. So.
Jenny's one of our former chiefs who just finished her crit care fellowship at Northwestern. So she came back and is working with Baronis, who runs the intensivist group at Christ. But she's working a bunch of nights, so she'd be a good person to get, I think.
Yeah.
Yeah, totally.
I saw on Twitter you guys were getting retweeted from the resuscitative TE account with like a bunch of our. I think was it Ken Dodd? I think I saw VJ. Who was there? What was that?
Yeah. Katie, you can tell them better than I can.
It was the crew, yeah. So the resuscitative TE workshop is kind of the first course that's really focused on emergency department and critical care physicians learning resuscitative TE, as opposed to cardiac anesthesiologists and cardiologists who have been doing it for a bit longer. So it's a course that actually uses the exact same sim trainer that we have in our sim lab, which is great because I've been teaching with this group of physicians for about 3 years now, since 2017, and so I get to kind of take a lot of the things that I learned from the course and bring them back to our residents and using this different program. But the course will essentially give you the simulation exams in a proctored environment such that people will take the training that they learn there, bring it back to their institution, and feel more comfortable not only in kind of reading or going through, a tape review of resuscitative TE exams, but also starting their own program, getting certified, things like that. So, the course goes all over the world, but because of COVID, travel restrictions, things like that, it's been a little bit more difficult, but we were actually able to hold a course in Chicago with a little bit more limited participants, but because people weren't able to travel as much, we did have more local faculty. So Mike Lambert came to teach with me, and a couple other people, Ken Dodd, and Jenny kind of came in a training position. And then like Mike Cerrone mentioned, we have a lot of ultrasound trained faculty at our shop. So it's not just us 3, there's, like 6 or 7 other people. And they came to take the course so that they can get certified. So I think we had, like 7 or 8 people at the course. It was great.
And you guys just got to hang out too, I'm sure, which was probably fun.
Great.
What do you think, like right now, the ultrasound world is echo crazy. That's been like the biggest leaps, it feels like, recently. What do you think the future is? I feel like you guys have better perspective. Is it improving echo? Is it newer technology? Mike, you've always got like toys in the department that you're playing with. What do you think the next step is?
One of the things that we're working with Echo News right now is with the artificial intelligence and the guidance for these new machines. And I think the artificial intelligence really helps us teach residents quicker. And that's where I think the real value is. And, to me, I think, people learn about 3 times as fast because this labels everything that you're looking at. So you don't have to ask what it is. You know what it is.
So you were showing me, I think, a model of one of these, which is basically you're doing an echo and you threw a probe on Aronson and then like his RV, everything got labeled on it. Is that right?
Right. Anterior leaf of the mitral valve, right ventricular outflow tract. Yeah. Interventricular septum. It tells you everything that you see on the screen.
And will they calculate like EFs and stuff?
It does. It calculates ejection fractions and cardiac outputs automatically. It saves videos automatically when you get the right picture. So it's coming.
So that was a free tip, I guess, by stock in AI. Kishi, I'm gonna put you on the spot here. Just returning a little bit towards career prep. What's the future hold for you, you think? How are you gonna like incorporate your fellowship or training into the future? And do you feel like you're getting good mentorship there or even like alumni networking and stuff?
Yeah, I think I'm getting great mentorship. Both Mike and Katie
Good
have been
answer.
wonderful.
Good answer.
If I said something else, I wouldn't have a job tomorrow. So,
No, that's not true.
No, I think the mentorship here is great. Luckily with Advocate Christ having the oldest program in the country, there's a lot of Advocate Christ ultrasound fellowship grads across the country. So, for me, location wise, it's still a little up in the air. I'm sort of looking at going back to Arizona. But either way, I would like to kind of use this fellowship as a bridge to kind of either getting an ultrasound director role or being involved in like more academics and have that ultrasound role that I could really help with. So that's kind of what part of my end game is, to advance the education and teaching of ultrasound. I think it's just going to get bigger and more prevalent in emergency medicine. And I can be kind of in the academic or director tract for that. I think that'd be really beneficial. Location wise, like I said, still up in the air, but that's the direction I'm heading.
Awesome. Will you guys give it that idea? We talked briefly about kind of the ultrasound conference days. Those are like one of the residents' favorite things to do is ultrasound days. Will you give us just give me an idea of like the most recent ones we've done, maybe what's coming up in the future, just to give them an idea of what that curriculum looks like what the topics were and what we were doing.
Well, the most recent one we did echo, TE, and ocular. We do 4 workshops a year for our residents, and it's pretty much most of the conference day anyways. And it's split into didactic and then we do hands-on. We try to get as much hands-on as we actually can. And I think, that's where they learn the quickest too. So we try to get the probe into their hands and get started on a different application. We really roll through, the 6, kind of core parts of ultrasound in emergency medicine, but we always try to, add some new things like, regional nerve blocks, whether or not it's hernias. We're always looking at something different too with ultrasound.
All right, before I open it up to anybody with questions, I want to have a little bit of fun. What's the coolest ultrasound you've done recently? Kishi, you can go first.
Oh man.
Or crazy.
I think I actually posted this one on the Twitter. It was just a kind of cool find. It was this gentleman who was involved in an MVC was having some chest pain, and that chest X-ray is normal. And we put the probe on him, and he had a sternal fracture.
Oh.
So it's kind of cool to see, like, chest X-rays they're going to miss, and saved him a CT scan. So that's just one that comes to my mind immediately. We did that last week. So
that's pretty cool. Katie, how about you?
Well, Kishi also had this really cool, like, pediatric endocarditis. Oh, yeah. That was awesome. So yeah, I know. Come on, that was really. It was like.
I don't know how I forgot about that. Yeah.
He's like looking at that, and he like sends me this video. I was like, that doesn't look good for that poor teenager. Let's see. My coolest. So I've been on maternity leave for 3 months, and I'm just back. I'm back yesterday. So I would say my most recent cool ultrasound maybe was of my own 3-month-old who's raging right now, if you can hear in the background, trying to go to bed.
Get Theo on the Zoom.
Yeah.
get him on
Sometimes
here.
I would like check in on him. Yeah. So, but he's all good. So
What'd you ultrasound? His heart? What'd you do?
just I said hi, like he's like, in my belly. He was in there. He was, waving.
Oh,
I don't know. Like, are you there? Yeah.
We're ultrasounding him
I
after.
did my own ultrasound.
Just to say hi.
I didn't ultrasound him.
All right. And Mike, how about you? Coolest thing you've seen recently?
Well, I don't know. This wasn't all that recent, but I love the application where, we used it to find these cactus that was stuck in this guy's hand. And you could tell by the rib of the cactus which way they were pointing. And he was from Thailand. And it's like, he had to catch a plane. So we did this pretty quick, just finding these, he had 5 different, pieces of cactus stuck in his hand. And only one of them you could see through the skin. It was coming out the skin. The other 5, we had no idea what direction they were headed. So we were able to each locate all of them and pull them out and get them back on the plane.
Did he get, I assume the cactus was not from the south side of Chicago.
No, that was in Arizona, and he fell off a bike and went on into a barrel cactus. And if Kish would know this, barrel cactus, they are big, curved, kind of strong needles.
Yeah, not very fun. Those things are huge.
I'll
That
finish
sounds
with,
cartoon, like it's not even a real thing, but that sounds crazy.
I'll finish with mine, Mike, because you'll love it, which is Mike always shows crazy pictures at lectures of stuff he has ultrasounded over the years. Like some of them are absurd. And I love when you go fishing for like soft tissue stuff. And so I use mine, the nurse, it was a patient sent from urgent care. They had a fish hook in them. And it was it actually went in and it broke when they were trying to get it out. So the fish hook was in still. And the urgent care was chopping around trying to get that thing out and couldn't get it. So they sent him to the ED. And so I did the Mike Lambert. I threw an ultrasound probe on, marked it, made my cut, just pulled it out. And they were so happy. Like it was like really the greatest thing I had ever done. So, sometimes it's not all the sexy echoes. It's the little things, right?
Yeah.
All right. We will, before we wind down here, I'll open it up to any questions. And then you guys can, you can feel free to either jump off or hang around to hear more if you can. I've got one here. There's a question in the thread. Where do you see the future of ultrasound going? In a short span of time, it seems to have moved from a niche field to a necessary universal skill that every ED doc needs to have. That is so true.
Yeah, I think it's going to be taught in medical school. I really do, because there's so many broad applications to it. I mean, we're getting requests all the time from internal medicine, from pediatrics, from really throughout the hospital. It used to just be the ER and critical care. Now the hospital is, everybody wants some education.
A couple of years, maybe 2 or 3 years ago, AMG, the cardiology group, pulled a couple of cardiologists over from other advocate sites that kind of joined over at Christ. And I remember calling one of them for a patient. It was a patient with a large PE. And this was before we had our PERT team protocolized. And so we called them basically with a bedside echo and sent them a shot of the RV. And the resident, we had just done TAPSE scores and stuff. And so we called this cardiologist up, and he called, it was one of these older, he's been in practice for a long time, but just came back to Christ. So I don't think he was used to this sort of thing. And he called up, and I remember he called me back on my phone because I had sent the pictures over Perfect Serve. And he's like, who is this? And I was like, I'm one of the ED docs. He's like, do you guys do this for everybody? And I was like, kinda, yeah. Like, I think this is sort of standard of care now, So it's crazy. If you've been away, I think when they come back, they're kind of shocked at some of the stuff that we're doing. But that's great. It's the right thing for the patients, Anybody else?
I had a question just about your guys' thoughts and opinions about the new butterflies. So I've had a chance to use some of these, and they're convenient. The images aren't necessarily the best, but I imagine it will only improve. So if you guys could just sort of speak to how you see that sort of fitting in, I'd be curious to hear.
Mike, do we need you to do a disclosure? Are you like invested?
No, I'm not.
Okay.
I'm not. Katie, you might want to answer this one too, but we actually just picked up a few of them for our own department as well. And, one of the beauties of them is they're so small, we can clean them really quickly. So during these COVID times, it's really good. The image quality of them, is really good. I mean, it really is for the size of that particular machine. Is it the greatest image quality? No, but it's for, I think for the size of it, it has a really good quality to it, and I think they'll be around for a while.
I think where we see where we see a lot of it is actually our intensivists who carry them around kind of in their pockets. McHale does it, a couple of them do, just because they're on so many floors and stuff.
Yeah.
So I think we get some exposure there.
And how we're ending up we're getting 6 handheld ultrasounds, is we applied for a grant that we got funding for because of COVID. So you guys have probably seen the giant ultrasound machines, which I love because they have a big screen and the image quality is so great. You wheel it into the room and do your exam. Well, when you're wheeling it into a COVID patient's room, the kind of wash down and sanitizing takes forever. And not to mention most of them have like little fans and you're just thinking like, oh my God, the COVID particles. But the fact that you have the handheld, it's so portable. And it actually, so Mike had shown a picture of us in Dubrovnik. So we taught a course actually almost entirely with butterflies attached to iPads there, because for some reason customs didn't get the Sonosite machines that we had agreed to kind of have shipped over there. So then we ended up asking all the faculty, being like, please bring your butterflies, bring your handhelds. And it actually ended up being really cool. It got our participants more hands-on time because I look over and there's 2 people scanning one model at the same time. There's like someone on the gallbladder and then someone else on the heart, and so it works for teaching as well. So
I'm gonna ask a couple more there in the thread here. They asked, did you guys get a chance to use ultrasound in some COVID-19 cases? And do you see any utility with these patients? I'll say briefly, it's just really interesting. The COVID stuff has evolved so much in every way, but in March, April, May, we had like hundreds or thousands of patients with COVID, but very little access to testing, at least none that would come. Initially, everybody was tested through the state or county health department, and there was a 7-day turnaround time. And so we really were guessing who had COVID. And a lot of it was based on biomarkers, right? Everybody got a fibrinogen, ferritin, LDH, procalcitonin, and then you were looking for basically leukopenic patients. They had like a very classic look, but previously in my career, the D dimer was like, we all dreaded the D dimer because when it was elevated, you had to scan these people. And then we reached this point with COVID where it was actually a D dimer cutoff. I think we were using 3, where we would just anticoagulate and just presume that they either had a small PE or were so prothrombotic that they were going to get one eventually. And so we were no longer beholden to like scanning all these people. And so that's when we started doing a little bit more ultrasound. So it was like this incredible guessing game because we couldn't prove that they had COVID, but we were pretty sure that they did. And then we couldn't scan all of them because initially the CT scanners would have to do a terminal clean for anybody who had COVID. And so instead what we were doing was looking for RV strain and like evaluating their D dimer and then anticoagulating in between. It was like a spy game for COVID. So that was kind of an interesting piece. I don't know if you guys had any other like.
Yeah, I had just 2 weeks ago, I had a 27-year-old who came in with like a Kerr sign in her right shoulder, just pain for the last 3 days. And, her belly was completely benign. She wasn't short of breath. She sat in 100%. And then she said, well, I had some pain over kind of, and she's pointing on her ribs on the right lateral side. And, we scanned, I took a look at her lung and she had an effusion there. And really her lung itself was collapsed a little bit in that spot, not pneumothorax, but just from the fluid and, bronchiograms in there. And, she's got a right heart strain. She ended up having a PE as well.
One practical application of the butterflies is when we first created the COVID units, when our first peak came and people were really sick, what the intensivists found is rather than going to each room and putting lines in or intubating, they actually created a sterile room where one of them would stay in a PAPR and the patients who were being admitted would wheel in. They'd get a central line, an art line, and intubated if need to, and then they would move out of that room. For a lot of times it was Ken Dodd or Ethan Estes, one of our chiefs, was in there a lot, and they would just sit there and do all the procedures because it decreased the amount of PPE used and exposure. And in those cases, it's actually really hard to get an ultrasound in there and cleaned and covered, especially if you needed to use it for something else. And so that's where the butterflies were coming in handy, because they were small enough that you could clean them and keep them in that kind of procedure room. And we're peaking again. I think that they may go back to that. They liked the short stay unit because they had those negative pressure rooms with room to do all their procedures. So that was kind of a practical thing. But let me do another one. Omar asks, what's the best way to get the most out of ultrasound on shift and studying at home? He's currently on a sub-I and has an ultrasound rotation scheduled later. So probably two good questions. One is on shift, how do you get the most out of it? And then how do you do it at home when you don't have a device to play with?
I think at home, if you're just more interested in like reading and looking at like examples of images and videos, there's the Intro to Ultrasound series. I think it was done by Mike and Matt. They have 2 volumes, but I feel like those are pretty useful. They're pretty easy to get through, and they actually have a lot of video clips, which is nice to see. And then on shift, I think, it's not only like just practicing I feel like half the game is the actual ergonomics of using the probe and how to hold the probe. So if you can have anyone there with you, just helping guide you, and then you can kind of, once you get some tips down and figure out the best ways to see, if you're doing an echo, what's the best way to get the forward chamber? Once you get some techniques down of trying to figure out or troubleshoot, then after that, you can kind of go practice on your own.
All right. Go ahead, Katie.
Just to say, another good website is the Life in the Fast Lane website. It actually has, I think, over 100 little ultrasound cases. And so those are quick ones where they'll show you a video or a picture and kind of set it up in a case-based format. And so that's kind of a good way to go through pathology, when you have some downtime.
Last call.
Yeah, those are great. And the Intro to Ultrasound books are free, just FYI. So.
Last call before we let everybody go. Any last questions before closing time comes on at the bar?
Yeah, I got one question. For you guys, are you noticing that your ultrasounds, especially in these COVID times, are sort of just completely replacing your stethoscopes? I just know it's really difficult to hear, and you have the PAPRs and those disposable ones and the filters in the rooms. And so do you find that the ultrasounds are kind of starting to replace stethoscopes, at least in emergency medicine?
I'll say at Christ, even pre-COVID, here's the hard part is the vast majority of our patients have underlying COPD, CHF, and CAD. They typically are not aware that they have these issues. And many times we see them in the hallway. And so I would argue our ultrasound probe replaced the stethoscope a while ago, because it seems like what we call a code 44, or like what that means is a sick respiratory patient. Basically, like when the residents come to help out for those, which is great, I love having them. We get in the room, we get N95s, and then they stand outside, and one of them has an intubation box and the other one has an ultrasound. And so that's sort of become our practice even before COVID because of our patient population. So yes, as the answer to your question, I don't know if you guys have a more specific comment on that.
Actually, the new Echo Noose has inside the probe, it also listens to the lungs.
Soon they will replace us.
Yes.
All right. I'm going to let you guys go. If you're interested in what you heard tonight or these wonderful teachers and people here, you can find them on Twitter. It's ACMC Sono, right? Is that right? ACMC Sono? Yep. Awesome.
Yeah.
Give Kish a follow. He just, he needs more friends. So. If you guys have any other questions, you can shoot us an email too. Very nice meeting everybody. Thanks for the participation and good luck. Stay healthy.